Good morning. My name is Oscar Perez. I'm an SGU, Master of Public Health candidate, and my Capstone Integrative Learning Experience, or CILE, project is a narrative review that is titled Reporting on Recent Successful Physician-Mediated Medication Adherence Interventions for Public Health Consideration. My CILE advisor is Dr. Satesh Bidaisi. As my project title suggests, my area of interest is mainly on exploring physician-led efforts to improve medication compliance and adherence. These are both very similar terms that refer to the likelihood of patients taking their medications as they were prescribed by their physicians. I chose to focus on medication compliance because it is currently at suboptimal levels, as described in Niakin et al. And Gu et al. Studies, which were both published in 2017, and because low levels of compliance have been linked to the progression of chronic diseases and worsening of prognosis, as suggested by Desai and Nayak in 2019. We're talking about here are diseases like diabetes, asthma, AIDS, and hypertension that require careful and dutiful compliance to limit disease progression. And the improvement of medication adherence could easily be the difference from a serious acute event and chronic long-term management. To resolve a problem that Young et al. In their 2017 study considered to have a bigger impact on patients' health than just the medication chosen, I decided to focus on physician actions because they're uniquely positioned to affect medication compliance. I sought to bring attention to a number of articles that had the potential to improve medication compliance. Ideally, these interventions that I'm going to highlight here are going to be tested down the line for cost effectiveness with an eye towards implementation. I used PubMed to create a list of 400 articles published on PubMed between 2017 and May 14, 2019, using the keywords medication compliance intervention to add 200 articles and the keywords medication adherence intervention to add the remaining 200 articles. I excluded studies if their interventions could not show a significant positive result in medication adherence, and if the interventions were too specific and not generalizable to most of the health field. If the articles as well were not available in English, I did not include them, and if the interventions were designed for non-physician health officials like nurse practitioners and pharmacists, they were also not included. This process resulted in 14 articles being divided into educational, financial, and ease of access, and personal categories. I defined the educational interventions as methodology that predominantly focuses on teaching patients or changing their mindsets regarding medication adherence. I define financial and ease of access interventions as methodology that primarily focuses on giving patients financial incentives to take actions or decreasing the complexity of medication compliance. Finally, I defined personal interventions as methodology that mostly focuses on improving patient-physician relationships. I found a number of potentially successful educational interventions in my search. A good deal of these studies, to name a few, Cooker et al. And Lin et al. Both in 2016, and Maddox, Ricks, DeLurgio, and Hummel, and Parkour et al. In 2017, were focused on face-to-face dialogue through motivational interviewing and psychoeducation. The idea there was to address some of the barriers that were commonly faced by the patients, so that on their own, they could handle these situations and be able to take their medications regularly. While psychoeducation and motivational interviewing were able to show an improvement in medication adherence, the studies that were performed by Dye et al. And Davis et al., which were both published in 2017, were particularly noteworthy. These studies required little to no direct contact between health officials and patients, and allowed patients to dictate their own changes to adherence. These interventions made use of relatively inexpensive methods, like monthly mailings, and access to a small online video database. Financial and ease of access interventions that I included in my review possibly suggest some of the most viable options for ensuring improvement of medication compliance. This is exemplified in Cook et al.'s 2016 study that showed that better medication adherence results were found not for motivational interviewing, but for scripted call reminders from office staff. Reddy et al.'s 2016 study proved that the use of adherence checking pill monitoring hardware which they considered to be relatively inexpensive, could increase medication compliance. A purely financial intervention, where there was a reduction in copay costs and financial incentives given to clinics participating in the program, which may not be particularly cost effective, was detailed in Kim, and Lee's 2017 study, which resulted in improved medication compliance. In contrast, Young et al.'s 2017 study, which I mentioned before, found success in improving compliance simply by changing medication schedules. The changes that were included were taking medication immediately after a meal instead of 30 minutes afterwards, and changing medication that was scheduled for evening time for morning time. Well, obviously some medications are set in a particular way and may require specific and rigid schedules. The generalization and implementation of this intervention should really be considered because it has shown an increase in compliance at minimal cost. Finally, the use of medication reminders via text messages, which were suggested in Milo et al. And Barletta et al., both from 2017, have also shown positive results in improving medication adherence. In my search, I only found two interventions that I categorized as personal interventions. The Purnell et al. 2017 study, which featured a two-way SMS system, simple message system, of medication reminders, appears to have low costs with low levels of patient involvement, which can still result in improved patient-physician relationships because of the feedback mechanism of being a two-way system. Larkin et al.'s 2017 study, on the other hand, places the focus on physicians and improving their efforts to educate and talk to patients regarding their medication compliance. And it found success in this endeavor, but it also did require the use of professional trainers for physicians, which may not be particularly cost effective. In conclusion, medication compliance, or how closely patients follow the instructions of healthcare workers regarding medication, plays an important role in both patient morbidity and mortality, and in creating financial stress in healthcare. A number of factors can be affected to try to improve medication compliance. In my CILE project, I explored the few options that already exist in literature and divided them into education, financial and ease of access, and personal intervention categories. Each of these categories of interventions have the potential to increase compliance rates. Educational interventions show compliance improvement, but may be limited by cost effectiveness due to time constraints and the cost of employing professionals for educational tasks. Financial and ease of access interventions show the potential to facilitate compliance measurements and to improve adherence through medication regimen restructuring and through medication reminders. Additionally, these interventions appear to be relatively cost effective, so the financial and ease of access interventions that I found seem to be the closest to implementation. The personal interventions category suggested improvements to patient-physician relationships that were likely to address factors that promoted non-adherence. Among the most seemingly cost-effective interventions that I reviewed, as I mentioned, were domestic medication reminders and medication regimen restructuring. These particular interventions could use more testing to really quantify their cost effectiveness. My review's results are limited by a small number of articles reviewed, and the specificity of each study that targeted a particular disease in a particular population in a particular location. Nonetheless, the articles and interventions mentioned here tell a promising story about the potential of medication adherence improving projects. I hope this presentation has shed some light on some of the recent successful studies that could improve the quality of life for many patients. Thank you very much for your time, and I welcome any questions or queries, which can be sent to my email, operez@sgu.edu. Thank you again.